Welcome to another edition of OrthoCarolina's monthly webinar series. My name is Dr. Ben Sutker, and I'll be talking tonight about common painful conditions and causes of elbow pain in active adults. This is being live streamed on our Facebook, LinkedIn, and YouTube platforms. And please don't hesitate to post questions in the comments section, and I'll try to address them all. So a little bit about me. I'm a bit of a unicorn. I'm a Charlotte native, born and raised. I went off to Chapel Hill and stayed for a long time. I did my undergrad, med school, and orthopedic surgery residencies in Chapel Hill. Then I went down the road, traded hospitals, but not basketball allegiances, and did my hand fellowship at Duke. I started out in academic private practice in San Antonio, where I was a clinical assistant professor of orthopedics at UT Health Science Center. Moved back to the East Coast and practiced with Optum Orthopedics in Savannah, Georgia in private practice, and then been very fortunate to move back home and practice with OrthoCarolina in our Fort Mill and Indian Land offices since 2018. So what I'd like to cover tonight is talking about the elbow from an anatomic standpoint. We'll touch on tendon problems, ligament problems. We'll touch briefly on fractures and arthritis. I'll try to point out what's serious and to be concerned about and suggest some things that can be helpful. So why does elbow pain happen? Well, certainly we see it with overuse injuries, with trauma such as falls, certainly with the explosion in racket sports and pickleball and paddle sports. We see a lot of elbow issues, common in weightlifters or folks that do repetitive heavy-duty work. And certainly if you've had a prior injury in your youth, it can come back to bite you as you're a little older as an active athletic adult. So when is it important to see a specialist? Well, not every elbow pain demands a trip to the doctor, but certainly if you're having pain that persists past 4 to 6 weeks, you're having sudden weakness, significant bruising after the injury, or numbness and tingling, or locking and catching, that's the time to have it evaluated by someone who specializes in elbow disorders. So I think it's important to take an anatomic approach, and just touching briefly, the elbow is a hinge joint that flexes and extends between the humerus and the forearm. It also rotates between the radius and ulna. The bones are covered by smooth cartilage, which allows for a smooth gliding motion. There are multiple tendons in the front and back and sides. And then deeper are the ligaments on the medial and lateral sides of the elbow. They're important for stability when lifting and throwing. The ulnar nerve is important to remember. We're not going to really talk about much of that tonight, but that's the funny bone nerve that runs on the inside part of the elbow and gives the feeling to the little and ring fingers and controls the small muscles of the hand. So we'll start talking about common tendon issues. So one of the more common things that we see is pain on the outside part of the elbow, known as tennis elbow. The doctor name for that is lateral epicondylitis. The lateral epicondyle is the bump on the outside part of your elbow, and that's the source of attachment for all the muscles that allow you to extend your wrist, your fingers, and your thumb. And as we get older, there can be some degenerative micro tearing of that attachment of the tendon to the bone, and that's what causes the lateral elbow pain. On the inside part of the elbow, similar things can happen to the common flexor pronator tendons. Those are the tendons that let you flex your wrist and pronate or rotate your forearm down. And again, there can be some degenerative micro tearing of those tendons here. This is what is known as medial epicondylitis, or commonly known as golfer's elbow. What are the treatment options? Well, certainly as things in most orthopedic ailments, we start with nonsteroidal anti-inflammatory, some topical meds. I did want to talk a little bit about injections, because a lot of patients hear that you just get an injection for this and you get all better. I commonly have patients sent to me by a PCP to see the orthopedist to quote unquote get the steroid injection. Well, there's a lot of good data now that shows that that's probably not the best idea. In fact, that injected patients are actually doing a lot worse at 1 year than uninjected patients. So it's kind of a quick fix that can give some short-term relief, but actually if symptoms return, the recurrence rate is higher and the pain is actually a little worse. So the bottom line is we try to avoid steroid injections for tennis elbow or golfer's elbow. You may have heard about PRP, or platelet-rich plasma. It gets a lot of play in the press, especially with professional athletes. And PRP can be a very good option for certain orthopedic ailments, but for tennis elbow and golfer's elbow, it really has not been shown to be much better than a placebo. What it will do is lighten your wallet quite a bit, because it's expensive and it's not covered by insurance, and it's really not very effective for either of these. So what does work? Well, activity modification, a counterforce brace that can be worn on the outside for tennis elbow or the inside for golfer's elbow, And then really the key to getting this better is a good eccentric stretching and strengthening program. So I usually start my patients with a home exercise program, but usually have them have one visit with the physical and ergonomics and some other things that can be helpful to prevent this. For prolonged symptoms that are not responding, then there is a surgical option. This is pretty rare in my practice, but this involves making an incision in the outer portion of the tendon, going underneath and debriding or cleaning out the damaged portion, cleaning out some bone spurs, and then reattaching the tendon back down to that lateral epicondyle. This can take a while to get better, with return to sports at 3 to 6 months and full activity at 4 to 6 months. But the results are usually very good for this. But again, this is for the refractory cases that don't really respond to conservative treatment. So what's the best approach? Well, it's important to know that most cases will resolve naturally on their own. I tell patients the good news is that this will get better. The bad news is it can take quite a while. But it is safe to use your elbow despite the pain. You won't really cause harm by using it. Conservative treatment really works well, modifying your activities, using the over-the-counter pain relievers, the physical therapy exercises, and the eccentric stretching and strengthening are really key. And the key message, again, skip cortisone injections, that patients and simple treatments really work better for this. Moving to the front of the elbow, the biceps tendon can be a source of pain. Usually these patients will have gradual front of elbow pain. It's different from the dramatic pop that you'll see with a tear that we'll talk about next. The tendon still remains attached, and there's very little early weakness, but it can be a source of pain. The MRI is shown here on the slide can kind of be helpful to show us the edema in the tendon and the degree of tendon involvement. This is in contradistinction to the distal biceps tear. This is the pop and the bruising with the Popeye deformity and loss of supination strength. This is pretty clear diagnosis clinically, but we often do rely on MRI to assess the degree of retraction. The treatment usually for this is surgical. However, in older patients that are low demand, sometimes non-surgical treatment can be entertained, and they do pretty well if they're a low demand. But usually if it's an active patient that requires good supination strength and good flexion strength, we'll do an open repair, reattaching the tendon to the bone. The recovery can take a while, 3 to 4 months to kind of get back to heavy lifting and work, and 4 to 6 months for sports. But we know that early repair gives the best outcomes. So if you're concerned that this happens, it's important that this is one where you definitely want to see a specialist because of that deformity and bruising and weakness. Just as in the front of the elbow, the triceps tendon in the back of the elbow can be involved as well. The triceps attaches to the point of the elbow and allows us to extend the elbow against resistance. This is commonly seen in men in the 40s to 60s from a fall and outstretched hand, sometimes with weightlifting or strength sports. And this is a sudden inability to extend the elbow against resistance. For partial tears, just like for the biceps, these can sometimes be rehabbed 4 to 5 months. But for a complete tear in an active adult, we do go in and repair these, usually with a very strong suture construct, using sutures that attach into the bone through what are called suture anchors, with a rehab over the course of 3 to 4 months, with a gradual return to sports by 6 months. And again, this is the key point, that if you can't straighten your arm after a fall or lift, it's important to get evaluated early, because earlier treatment does give better results. Staying on the back of the elbow, I did want to touch on olecranon bursitis. This is a common entity that we'll see where there's swelling over the tip of the elbow. The olecranon bursa is a small cushion between the skin and the bone that protects that, and this can get irritated and inflamed with pressure on the elbow, such as leaning on the elbow. It occasionally can be seen with gout or rheumatoid arthritis. Desk workers or folks in the trades that are crawling and leaning on their elbow a good bit. And this is the typical clinical presentation. It's important to distinguish between a septic or infected bursitis and non-septic or non-infected bursitis. The majority of these cases are non-infective. It's usually from a pressure where there's swelling and fluid buildup, and the treatment is what we call PRICE: protection, rest, ice, compression, and elevation. For the uninfected cases, there's really not a need to stick a needle in there and draw the fluid out. There's some concern that by doing that, you have the chance of introducing bacteria into the bursa and converting a non-infected bursitis into an infected bursitis. The septic bursitis tends to present with a high fever, more pain, redness. In those cases, we often will stick a needle in and aspirate the bursa to guide treatment, and then that can usually be treated with oral antibiotics for 2 weeks. Surgery is reserved for the more recalcitrant cases or recurrent infection. It can either be done open, as shown above there. I really don't love this operation just because the skin envelope, especially in older folks, is pretty fragile, and there can be some significant wound complications. There's a trend now to trying to do this arthroscopically, as shown in that bottom picture there, which avoids the big incisions over the tip of the elbow. The key with this is that if you do have a high fever or there is a break in the skin, then that's important to get evaluated promptly in case this is a septic bursitis. Moving a little deeper, talking about the ligaments now, as we discuss, ligaments attach bone to bone, whereas the tendons attach muscle to bone. The ulnar collateral ligament is the one that most people have heard of. This is the Tommy John injury. Tommy John was a baseball player that had the first reconstruction and went on to pitch in the professional leagues for about 14 years after this. That elbow protects the inside part of the elbow from stresses seen with throwing or overhead sports. It can present with either an acute pop or gradual pain with looseness and fatigue, loss of velocity in throwers, weakness with overhead activities such as serving and tennis. If it's a partial injury, sometimes these can be rehabbed with a structured physical therapy and adjusting throwing mechanics or sports mechanics. But for those high demand patients that require strong elbow for throwing, then a surgical reconstruction using a tendon graft can restore their stability. This is a gradual return to sport. It usually takes 9 months, sometimes even more, to get back to the former level. But 80 to 90% of patients that have this repaired, that are high-level athletes, have good to excellent results. Similarly to the inside part of the elbow, the lateral elbow complex can also be involved. The lateral collateral ligament anchors the bones on the outside, and this can lead to something that's a mouthful. It's called posterolateral rotatory instability. We'll just call that PLRI. That's a lot easier to say. But the lateral collateral complex can be injured most commonly after a dislocation, with a fall, or with prior trauma. These can present late, with patients having symptomatic feeling that the elbow wants to shift or pop out of joint or give way. They have difficulty pushing up off of a chair or doing push-ups, may have some snapping or clicking in the elbow. Rarely that can be treated non-surgically, but for patients that are having symptomatic feelings of subluxation of the elbow, where the elbow is tending to pop in and out, and that is also reconstructed, usually with a tendon graft, with a gradual return to lifting in sports over the same course, with usually good results. And the goal is to restore that stability of the elbow so that the joint itself does not wear out. We'll move on to some common fractures in the elbow. All of the bones that we mentioned there initially can be injured. The radial head is the upper end of the radius bone that allows the forearm to rotate. It's a secondary stabilizer of the elbow. Usually this is from a fall onto an outstretched hand, and the force of that fall drives the head of the radius up into the humerus bone, causing these types of fractures. These patients can present with lateral elbow pain, swelling. Interestingly, about 30% of these can be occult fractures, where they're not really seen in the initial x-rays. So if there's a high index of suspicion, often we'll splint the patient and repeat an x-ray at 10 to 14 days. The treatment is really based on the severity of the injury. For the non-displaced fractures, these can usually be treated non-operatively, but for multi-fragment injuries, it can be treated as shown in these slides, with either some small screws, either with a screw and plate, or sometimes even for the multi-fragmented, more than 3 pieces kind of fractures, we'll do what's called a radial head replacement. But the majority of these non-displaced fractures can do well without surgery, and again, early motion is a high priority. Moving to the back of the elbow, the olecranon is the tip of your elbow that you feel when you lean on your elbow, and this is a pretty common fracture. This is about 10% of all upper extremity fractures in adults. This is usually from a direct blow where one falls on the elbow that can drive the humerus into the joint there, fracturing the tip of the elbow. As you can imagine, your triceps inserts right here, and the pull of the triceps keeps that fragment displaced there. So the majority of these, if they're displaced, these require surgery because one's not able to extend the elbow against resistance. The surgical options include tension band and wiring constructs as seen here, but most of us now are going to these pre-contoured plates, which are anatomic, allow us to fix the joint rigidly and allow early motion to restore the motion of the elbow. The one caveat is that, as you can imagine, the ulna is a subcutaneous bone, and sometimes this hardware can be symptomatic, requiring removal down the road at about 12 to 18 months. But again, the key is if you have a fall and you're unable to straighten your arm against resistance or even straighten it out, then that's important to get evaluated pretty quickly. And distal humerus fractures, or the fracture of the end of the humerus into the elbow joint, these are terrible injuries. We see these in two sets of patients, usually younger patients with a high energy trauma. The other folks that we see this in is osteoporotic older adults here. These usually are associated in pretty obvious injuries with severe pain and swelling. A CT scan can be very helpful for planning. As shown here, this is a three-dimensional CT scan that's very helpful for us to kind of identify all these fragments. As you can imagine, this is sometimes like a jigsaw puzzle that can be very hard to put together here. The majority of these, we try to rebuild the joint and get everything anatomic so we can start early motion as seen here. Occasionally, and this is really only for older patients that are low demand or may have some pre-existing arthritis, patients over 65 to 70 years old, we occasionally will perform a primary elbow replacement, but there's fairly rare indications. And the young and active patient, it's always better to try to preserve the native joint. So we'll try to reconstruct the elbow and get it moving early. So we'll move on and talk a little bit about elbow arthritis. So arthritis in the elbow, it's less common than arthritis in the knee or hip. Arthritis is a wearing down of the bearing surface. I tell folks the tread on the tire kind of wears out with age. Primary arthritis is less, as I said, less common than in the hip or knee. Post-traumatic arthritis after trauma can develop many years later. We occasionally will see rheumatoid arthritis or gouty arthritis in the elbow. But primary arthritis is usually in men in the 40s to 60s that have done a lot of manual labor, used vibratory tools, or had a history of a lot of throwing and weightlifting. Arthritis presents with in-range pain, usually associated with some stiffness in the elbow, some locking or popping, and loss of the functional arc of motion. The exam is correlated by a good physical exam with x-rays. CT scans can be very helpful for us to evaluate the joint surfaces. And again, we usually start with conservative treatment with activity modification, therapy, anti-inflammatories. This is one entity where steroid injection can be helpful, but judiciously, not more than once every 3 months or so. Arthroscopy can be helpful. Certainly a lot of patients with elbow arthritis will have loose bodies that can break loose into the elbow. These can kind of cause locking or sticking of the elbow where something is getting stuck in the hinge. The arthroscopy can be very helpful to go in and look for these loose bodies. You can kind of see one here floating around the joint. We can go in with a minimally invasive technique with the arthroscope, remove those, clean up some of the inflammation in the front and the back, and allows a very good resumption of motion and stops that mechanical symptoms of the elbow getting locked or stuck. A step up from that is something called an arthroscopic osteocapsular arthroplasty. That's a big mouthful, but basically for more advanced arthritis, we can go in with the arthroscope and remove spurs on the front and the back, remove a lot of the inflamed synovial tissue, release the capsule to kind of restore motion. Very good for patients that have mechanical locking or actively limiting pain. And really, this is probably the best operation that we have for arthritis in the elbow. It's designed to keep our active patients active. And the results are really quite good, 98% survivorship at 10 years. The arthritis can recur with the osteophytes regrowing, and sometimes we'll do a secondary procedure 10 years down the road or so. Obviously, the worse the arthritis is, the worse the prognosis is. Our treatment ladder for elbow arthritis, certainly we start with the conservative things, arthroscopy, sometimes open procedures. Elbow replacements, unfortunately, are not at quite the level that they are at the hip and knee. So that's really reserved for our lower demand elderly patient. The ideal patient for that is an elderly female with rheumatoid arthritis, because if you have an elbow replacement and you have a lifetime lifting restriction of 5 pounds because the joint will just wear out. And the revisions are pretty common at 10 to 20 years. And a revision elbow replacement is a much more difficult and complicated operation than a revision hip or knee replacement. So most patients treated with the arthroscopic techniques or the open techniques, preserving their own elbow joint, can regain functional motion without a elbow replacement. So that's our whirlwind tour around the elbow. I'm happy to take your questions. And I got to hit. There we go. Oh.
There you go.
All right. So what is the best surgical procedure for chronic elbow tendonitis? So, as I mentioned there, we really try to treat things conservatively. So a good anti-inflammatory program therapy. But for those patients that are having pain for more than 6 months, then going in and doing the surgical debridement with the reattachment of the tendon, where we go in and excise the damaged portion of the tendon, preserve the good part, and then reattach it, as I showed in the slides, can be very helpful for that. So let's see, I've had cubital tunnel release, carpal tunnel, and CMC joint replacement on both hands, but still have the same, if not worse, numbness and tingling on both sides. Would any further treatment help? So that's a pretty complex question. There can be a lot of reasons for patients having persistent numbness and tingling after having surgical release. I don't know, diabetes, older age, the chronicity of the nerve compression before the surgery can all affect that recovery. So, that would need a pretty thorough workup, maybe some repeated electrodiagnostic studies to kind of figure out exactly what is going on. That's not one that you can kind of really answer with one quick answer here without, doing a pretty thorough evaluation. How can I protect my elbow while biking? So, I was a pretty avid cyclist there. So I'm not exactly sure. Certainly using elbow pads if it's the trauma from the impact of the handlebars. Wearing good padded gloves and double wrapping your handlebars can kind of limit some of that impact load. But the elbow will get a lot of load, as does the wrist, certainly with mountain biking, less so with road cycling. But there's not, great ways. In terms of, mountain biking, if you're getting thrown, using an elbow pad or some kind of guard can kind of be helpful for that as well. What is the difference between a brace and a compression sleeve? Great question. So a compression sleeve is usually neoprene or other materials designed to, just as it says, give some compression, which can help with what's called proprioception, which is how your brain recognizes where your joint is in space. That can help reduce some of the swelling in the elbow or knee or whatever joint, as opposed to a brace, which is designed to be a more rigid construct to kind of help limit motion in certain planes. So, for example, if there's in the elbow, if there's pain with the elbow coming out into full extension, we'll sometimes use a brace that locks out the last 15 degrees of extension, which can be helpful. We'll often use a brace sometimes post-op after a ligament reconstruction, just to give some more external support for that ligament reconstruction while it's healing. If we were to need joint surgery, can you generalize about what age is optimal? For example, are 80s still okay? Are 90s too late for such procedures? So if we're, that's a really general question. So I can't really comment on the specifics of hip and knees because I really don't do that type of surgery. I'm just elbow, wrist, and hand. For elbow arthritis, as I mentioned, the indications for a total elbow replacement are pretty narrow. But certainly I've seen, age is just a number. So I've seen some really healthy 80-year-olds and 90-year-olds that are having activity limiting pain. The caveat is that with, the elbow replacements, there is if you're an 80-year-old and you're telling me you're still out on the pickleball court, 5 days a week, or you're lifting weights and doing a lot of stuff, an elbow replacement is not, an ideal operation for you. That's not the same with the hip and knee, which are much more reliable. Okay, my elbows sometimes make a snapping, popping noise on extension, but it does not hurt. Is there something I should be doing to fix this? Great question. So, we talked about the locking and snapping that one can see with loose bodies in the joint. I often will tell patients, sometimes our joints can kind of be mechanical and they can make some noises. We're not exactly sure. There's a lot of theories on why that happens. I tell folks that if it's not causing pain or not causing a block to motion, it's really not anything significantly to worry about. I get more concerned if you're having locking and snapping that's blocking your motion, such as it feels like something's getting stuck in the hinge and you have to kind of jiggle it to get the elbow loose. That's more symptomatic of what could be a loose body. And again, that's where, an arthroscopic procedure could be helpful. Certainly we would start with appropriate imaging and a good physical exam first. But if it's just locking and pop, or just a popping noise, it really doesn't hurt. Not really anything necessarily to be terribly concerned about. Let's see. I've had a radial head implant that turned out to be too large, and it prevents me from straightening my arm. How common is this, and what is the replacement surgery like? Yeah, so we're diving into some good technical questions here. So one of the things, radial head replacements are great operations, but you do have to be kind of careful with the size. And one of the things that we can see is what's called overstuffing the joint. And if you don't get the joint exactly level, it can cause a block to motion. Depending on what type of implant was used, it can be revised. And again, depending on what type of implant was used, that can be either fairly straightforward or fairly complicated, but certainly starting with some good basic x-rays, kind of looking at, certainly if the older x-rays are available to kind of compare what's going on with the elbow. And a lot of it also depends on what the original injury was. If there were associated ligamentous injuries or other things, there can be some other things that can block motion there. So that's a pretty complex question, but certainly there are some options for it to improve things. Okay, when road biking, I tend to feel a sharp burn in my elbow very early on in the ride. Does that typically indicate tendonitis? It depends on where that is. If it's in the back of the elbow, certainly the triceps can get a lot of stress from the impact there. If it's on the inside or outside part of the elbow, if that kind of loosens up as you're riding, that may be a little tendon irritation. The other thing that, is very common in cyclists also is irritation of the ulnar nerve. We talked about that funny bone nerve that runs under the inside part of the elbow and goes down to the small and ring fingers. There's something called a cyclist palsy. That can either be from pressure at the wrist over where the ulnar nerve runs, but it can be if the elbow is held in a bent position, if you're really down in the drops of the handlebars, that position can cause some of the burning pain that can sometimes radiate down into the ring and little fingers. So it really depends on where that quote unquote burn is radiating to kind of know exactly what that is. So any advice for swimming crawl stroke, any motions to avoid overusing the elbow joint? So I used to swim a good bit when I was doing triathlons before my knees wore out. So that's a really great question. A couple of things is certainly making sure to stretch well before you swim. So stretching your shoulders and the elbow there. If you're finding that certain strokes like the crawl are causing elbow pain, it might be helpful to have an instructor kind of look at your stroke to see if there's an abnormal motion there. I tend to see more shoulder issues with swimmers than elbows there, but swimming is a great exercise because it's the low demand doesn't put a lot of pressure on your joint, so it's pretty unusual for it to cause overuse injuries of the elbow unless there's something abnormal about your stroke, or if you've had a prior injury to the elbow that causes some aggravation. But I'm all for swimming. It's a great exercise. So what is your opinion on wearing a brace to support my elbow? Will it help to wear it when playing pickleball? So again, this kind of gets back to the compression sleeve versus brace question that we had earlier. It really depends on what you're trying to use it for. If it's just elbow pain, sometimes using a compression sleeve, if it's more of a soft tissue injury, if there are instability type symptoms, as we talked about, before, then, a brace that kind of helps support the elbow can be helpful. A rigid brace is probably going to be a little too rigid to allow you to play pickleball if it's your dominant arm, where a compression sleeve would probably be more helpful in that case. Is elbow tendonitis or arthritis genetic? Great question. So elbow tendonitis really is not. That's more, as I tell folks, a disease of life. As we get older, our collagen gets a little less elastic and is less able to withstand some of the forces that we put them to. And so, tennis elbow, golfer's elbow, pretty much a high number of folks after the age of 40 are going to get this at one point. But, the good news is, as we said, it's usually self-limited, usually goes away on its own by 6 to 12 months and usually doesn't come back. Arthritis, on the other hand, yes, that certainly can be genetic. Both osteoarthritis, which is the wear and tear arthritis that we see with life, can be genetic, and certainly rheumatoid arthritis, which is the inflammatory arthritis, definitely has a genetic component. Does sleeping on my side put me at higher risk for developing a shoulder injury? No, not necessarily. What if cortisone shots in my elbows stop working as well as they did? So again, kind of getting back to what I emphasized in the talk there. I mean, I will maybe do one cortisone injection if we're talking about tennis elbow or golfer's elbow here. I would assume repeated injections really are not a great idea. We talked a little bit about the lateral collateral ligament injury, and I have seen patients that have had iatrogenic ruptures of their ligament from multiple cortisone injections done elsewhere there. So if we're talking about injections for tennis elbow, if the routine therapy and conservative things aren't working, I would definitely recommend avoiding repetitive cortisone injections in this case. Let's see. I had tennis elbow for about 6 months, low pain level. Pain responds to anti-inflammatories. Is a shot only masking the healing of the tendon? Do I need more rest in PT? Excellent question. Thank you. You're kind of making my point for me. So. As we mentioned, the shot can kind of short-term mask. And I tell it's a short-term gain, but for long-term pain. So the key is activity modification, kind of avoiding the things that are causing it to flare up. Being really religious with your concentric exercise program, doing eccentric stretching and strengthening. Anti-inflammatories and tincture of time, and understanding that if the elbow is painful with certain activities, you're not necessarily doing harm, and the majority of tennis elbow pain will burn out. But again, 6 months is kind of average. It can take 6 to 12, and patients don't love hearing that because we want instant fixes there. But avoiding shots certainly would be my recommendation. So after an elbow injury is healed, can I return to my sport of play at the same level I was previously? So that's a pretty wide open question. It really depends on the elbow injury, whether we're talking fractures, ligament injuries, tendon injuries. But in most active adults that our goal is to fix the elbow as anatomically as we can. We can't make it as perfect as it was before the injury, but our goal is to get patients back to a functional level. So the majority of patients are able to return to their sport of play at the same level, but that question is really dependent on what particular injury we're discussing. Am I damaging the tendon if playing through the pain? Great question. If it's activity related, such as tennis elbow, golfer's elbow, and it improves and with stretching, and you're kind of playing through it and it's not inhibiting your play, it's perfectly fine to do that. I often tell patients, if it's painful, you're not making the elbow worse. What I would be concerned about is kind of a sharp pain where you suddenly really can't move the elbow well, or it's really bothering you, not just with sport. Then that may be one where a enforced period of rest, some anti-inflammatories, doing some gentle rehab, giving the elbow a chance to recover, and then trying to resume your sport or playing through it later. How can someone distinguish between muscle soreness and the onset of a serious elbow injury. So that kind of goes back to that slide that I showed on when is it important to see a specialist. So, muscle soreness is pretty common after doing, a workout or doing a sport that maybe one's not quite used to. And that will usually resolve in, 72 hours, sometimes a little longer, responds well to heat, stretching, anti-inflammatories. A more serious elbow injury is one that would be associated with, significant weakness or numbness and tingling or clicking and popping or pain that wakes you up at night, that kind of thing, or pain that persists for more than 4 to 6 weeks. That would be one that would merit evaluation by a specialist. Any dietary or supplements which help maintain healthy joints. So there is a lot out there. Glucosamine and chondroitin were the biggies in the past. And that has been shown in the lower extremity for hips and knees to be a little helpful there. There's not a lot of great data in the upper extremity. Some patients have done well limiting inflammatory agents in their diets, and that can kind of take some guidance from a good nutritionist. Some patients are very sensitive to dairy. Some patients are very sensitive to carbohydrates, and so a low carb diet has been helpful for some patients with painful joints. This is one where it's hard for me to kind of recommend a specific supplement. The issue with these, and I always tell my patients, is they're not regulated by the FDA, so we're not sure what's in them a lot. And there have been some popular ones that have been pulled off the market recently, but certainly it is not problematic to use these and experiment if you find a good one. But you have to take them for a while. As long as they're not causing significant side effects, if you see a benefit, certainly it's worthwhile to try these. But you got to be a little wary about advertising. A lot of these make some claims that really aren't supported by good scientific studies. Do repeated elbow injuries increase the risk of arthritis later in life? Again, really depends on what the injury is. So, arthritis is an injury to the cartilage or the bearing surface of the joint. So certainly, if one has had a fracture previously, that can predispose you to post-traumatic arthritis. Pretty rare to have, repeated fractures. We did talk about the elbow dislocation and the lateral ligamentous instability. One of the thoughts is if the elbow is continuing to be unstable, one of the reasons that we repair those ligaments is to prevent that damage to the cartilage. So if one is, repeated elbow dislocations where the elbow is unstable, that would be one that we would try to reconstruct to restore that elbow stability so that the cartilage is well preserved and doesn't degenerate to have an arthritis down the road. Can I get tennis elbow from playing golf? Yes, absolutely. So tennis elbow is a little bit of a misnomer, and so is golfer's elbow. So the majority of patients that I see that have lateral tendinopathy, most of them don't play tennis, and same thing from the pain on the inside elbow from golf. So I have definitely seen golfers that have pain on the lateral elbow, and it can be related to stress on those extensor muscles, sometimes with the swing. And again, the treatment options are a good dedicated rehab program, anti-inflammatories, stretching, sometimes using the counterforce brace. But yeah, it's not all lateral elbow pain is from tennis. What does numbness or tingling in the hand indicate about possible nerve involvement in elbow injuries? So, specific to the elbow, we talked about the ulnar nerve. That's the funny bone nerve that runs in a little tunnel on the inside part of the elbow. That nerve gives the feeling to the little finger and the half of the ring finger. It also controls the small muscles of the hand, what are called the intrinsic muscles, or the muscles that allow us to do fine manipulation, pinch, and grip. And so if there's been a significant elbow injury that can cause swelling around that tunnel at the elbow, most of the ulnar nerve symptoms, patients present with numbness and tingling in their little and ring finger. They may note some clumsiness or weakness in the hand. With prolonged compression, they can actually have some loss of those intrinsic muscles or some atrophy of the muscles in the hand. But the usual presentation, it usually starts with symptomatic numbness and tingling, especially with the elbow bent or held in a flexed position for a long period of time. And that's usually what we initially start with, is kind of avoiding those positions that cause excess pressure on the nerve. But certainly if you're having those kind of symptoms, it's worthwhile to have it checked out by someone who knows what they're doing. Is ice or heat better for an aching elbow? So this is a question that comes up a lot with orthopedic injuries. So it really depends. So for an acute injury where there's acute inflammation and pain and swelling, ice certainly is very, very helpful. So it's important. Use it really only for 10 minutes at a time and take frequent breaks. Using it too much, you can actually get potential mild frostbite there. So in the acute injury, ice is usually better. For a more chronic injury where the joint is sore, most patients find that moist heat or even a dry heat can be better for aching elbow pain. For more arthritic type pain, most patients find the heat is better. What exercises and activities do you like to participate in to keep your joints safe? So, any kind of weight-bearing exercise is great. So just simple walking. If you can't, running is a great exercise, but it can kind of be pounding on your joints. So, I guess really we're talking more about, lower extremity here, but any kind of weight-bearing exercise, as I mentioned, swimming is a great exercise. It doesn't put a lot of load on the joints, can kind of be helpful to keep both upper and lower extremity joints healthy. Cycling is another great one that doesn't, cause all the pounding on the joints that running does. But any kind of weight-bearing activity is healthy for bone health overall, to prevent osteoporosis and to keep your joints healthy. And that can be as simple as just, walking in your neighborhood, walking your dog. And you don't need a weighted vest. I know there's been a huge proponent of folks and I've done that. I've walked with a weighted vest when I was training to go hiking in Iceland. But just simple walking with your spouse or with your friend or with your dog can kind of keep you mobile and keep your joints healthy. Well, great. Well, thank you all for attending. This will be sent out as a replay on all of our social media channels. And I certainly appreciate everyone taking the time to be with us tonight. And I hope this was very helpful for you. Thanks.